Okay, so thank you for giving me the opportunity to talk about this study. I like to think that it's innovative from two perspectives. One, that we are utilizing an innovative way of getting data, which is patient-derived data, for medical research. And we've also incorporated patients into our investigative team. And we believe that that gives great strength to our study because it's keeping the patient as the focus. So we believe it truly is empowering Waldenström's macroglobulinemia patients to drive medical research. So I'd like to acknowledge and appreciate the funding that Janssen provided to BioGrid Australia for the WM-specific amendments to Cartwheel, which is the platform which we've used to gather our data. They've had no access to the data itself or any role in the data analysis. So what is Waldenström's macroglobulinemia? It's a low-grade non-Hodgkin's lymphoma, and what that essentially means is that the bone marrow is infiltrated with cells like these, which are sort of halfway between a lymphocyte and a plasma cell, and it also requires there to be a circulating monoclonal immunoglobulin, immunoglobulin M, or the macroglobulin, which is monoclonal, meaning it's produced from cancerous cells, from one line of cells. Its incidence of 3 per million persons per year would obviously classify it as a rare cancer. And while it's often asymptomatic, it has a wide range of symptoms that it can manifest as. And so you can imagine it's important for doctors to get a better understanding and a better real-world picture of the WM patient, which is one of the main reasons why we did this research. One of the few benefits of WM is that it's got easy monitoring of disease and treatment response through clear markers, which are the immunoglobulin M, or IgM, and hemoglobin. A major indication for treatment of WM is development of symptoms, and chemotherapy up until now has been the mainstay of therapy. The other advantage WM has over other lymphomas is that there's now a decent list of novel therapies that are becoming available, and in trials, clinical trials, currently have been shown to be effective. However, they're very expensive, and a lot of them are not Therapeutic Goods Association approved or on the pharmaceutical benefits scheme. And so this highlights the disparity between what clinical trials are telling us are best practice and what is actually going to be available for clinical practice here in Australia. So rare cancer is defined as an incidence of less than 6 per 100,000 per year. And there's a term called less common cancer, which is 6 to 12 per 100,000 per year. And what I found fascinating was that the incidence per year in Australia of rare and less common cancers is more than the combination of the top 3 cancers, which is prostate, colorectal, and breast cancer. However, it's, as I'll show you, the funding doesn't reflect that. And one of the other major problems with rare cancers is that because it's rare and it's difficult to recruit, it's difficult to complete high-powered clinical trials in a timely fashion. And so, one, the clinical trials don't reflect the real-world dilemmas such as funding and availability, and 2, it causes significant delays in treatments becoming available for patients. So as you can see, this is where patient-derived data would be valuable, because if we can capture all the patients, or as many as possible, to give their own data and provide a big data set, it would have a significant power to match that of the clinical trials done conventionally. This form of patient empowerment has been shown to benefit medical research, changing clinical practice in some fields, as well as its direct empowerment of the patient. So this graph is a little bit busy, but what I want to highlight is that in the green columns, you can see on the far right that the less common and the rare cancers have a high proportion of death per diagnosis. And the blue column in the middle shows its burden of disease compared to all cancers. So you can see that quite a lot of the cancer burden in Australia is less common or rare cancers. But then you look at the first column for each category, the dark blue column, and in fact I can use the cursor, you can see that the funding for rare cancers is proportionally much less. So where does WhiMSICAL come in? First, I'll describe what cartwheel is. Cartwheel was founded by one of our co-authors, Associate Professor Claire Scott, and it's the Center for Analysis of Rare Tumours. It's essentially a rare cancer database that's ethically approved, privacy protected, and it's internet-based, and it collects its data through a questionnaire. Now, obviously, it's available globally, being on the internet. Patients sign in, they register, they sign in, they can sign in multiple times and update their data, and they provide their demographic data, details of their tumour, all of which they'll be getting in reports from their clinician, and the treatments they've had, other history, as well as psychosocial questions as well. Now, obviously, most doctors will look at this and say it's patient-derived data, this is unreliable. The cartwheel.org group have already done a quality assurance study with the Peter Mac Cancer Center Sarcoma Clinic showing a 75% correlation with clinician-entered data. So for us, in the big data setting, that's significant and is very meaningful. And currently, cartwheel.org is facilitating multiple clinical trials. So just to give you an idea of what the questionnaire looks like, this is when someone's logged in. They're putting in their information of where the tumor has derived in their body and whether it has metastasized. So you can see that the questions are using simple language, and it's quite directive to try and extract the accurate information. This is another example of the capturing the treatment data. Where did you have treatment? The name of the treatment, how did you access the treatment, the start date, the end date, or whether it's ongoing. And finally, one of the great powers of cartwheel.org is that it provides the patient with a summary at the end of the completion of their data. And this summary isn't a one-off. They can print it off each time, review it with their doctor, and show it to their doctor and fill in any gaps. It will allow their doctor to see the gaps in their patient's understanding of their disease. So it has a lot of benefits in that regard. So the aims of this study was obviously directed for Waldenström's macroglobulinemia. And we decided to utilize cartwheel.org and the excellent connectedness around the world of WM patients to gain a better real-world understanding of WM. We plan to gather data on symptoms and pathology, so the IgM and the hemoglobin, at presentation and treatment, and around treatment. And obviously we want to gauge what actual treatments are being given to patients in the community, how they're tolerated, and disparities between Australia and the international community. So how we went about doing that was we have clinician and patient investigators coming together and developing an extension to the cartwheel.org questionnaire. This was HREC approved, and we had specific questions added to extract that data of symptoms, pathology, and importantly, we added the treatment access question as well. And we're achieving continuous recruitment through the patient community group, WM Aussies, the leader of which is Andrew Warden, who is a co-author and who was instrumental in getting this project running. And the Leukemia Foundation has played a great role as well in our recruitment, as well as communications with the Haematology Society of Australia and New Zealand. As I mentioned, participants are actively encouraged to print the summary and review the gaps in their information with their clinician. Once we've established feasibility, we're going to, and we've already established communication with the International Waldenström's Macroglobulinemia Foundation to allow for an international rollout and capture patients internationally. So this is just a screenshot of the extra question that we've added. It's our whimsical question. There's much more to it, but that's just the beginning to show you how symptoms are captured. So we've only gone live 3 months ago, so it's still in its infancy, and we've managed to, what we're proud to say is we've managed to capture and recruit 50 consented patients already. Obviously, the majority of these from Australia, but we've had some international buy-in as well. Reflecting what's in the current literature is that almost 3/4 of the participants were male, and the majority were over the age of 60 with a median age of 66. Now, something that isn't generally captured that well in prospective randomized clinical trials, which are the highest level of evidence, is the symptom of fatigue. It's either not asked for or it's not well asked for. But we found that 62% of people who listed their symptoms mentioned fatigue, and that's obviously quite an important thing, particularly because symptoms are the reason to start treatment, and fatigue can often go ignored. Other prominent symptoms are neuropathy, leg cramps, and B symptoms, which are fevers, night sweats, and weight loss. It's a bit early on to try and give a good picture of the typical presenting WM patient, but we're getting an idea of the typical IgM level at diagnosis, as well as the hemoglobin. In our cohort so far, they're bordering on anemic. Now, I quite like this slide because, one, it shows two things. One, that we've got patients who've had up to 6 lines of therapy. The majority have only had 1, but you can see that they can have quite a few lines of therapy. And what I found really interesting was that of the 26 people who had listed their treatments, 22 different therapeutic regimens. So that means that there's really no consensus to treatment, and there's no clear guidelines to this rare cancer because it's not very well understood. The other interesting fact is what is considered best practice in first-line treatment is rituximab therapy, a type of immunotherapy. It's not PBS listed in Australia for first-line use. However, half of our patients in Australia did manage to get their hands on it somehow, so we're not exactly sure. We're waiting for all the access data to come through, but we found that really interesting. So what does this all mean? What do our results tell us? Basically, I think we've clearly established that it's feasible to gather the data. We've already gotten 50 patients in 3 months, and we've got a Project 100 to try and recruit 100 participants from Australia and New Zealand. And there are some gaps in the data, but these gaps are being highlighted and being advised to the participants through our communiques through WM Aussies to try and improve that gap, and we are also encouraging them to go back to their clinicians to fill those gaps. And we believe that we will be able to achieve our Project 1000 a little optimistically, but we hope so, and by doing that we obviously need to roll out internationally, and we're already gathering the support of the international WM patient network, and once we get that sort of big data, we'll definitely be able to increase the breadth of knowledge of this rare cancer. To facilitate this international rollout, we will be presenting the updated data in October this year in Amsterdam at the International Workshop of Waldenström's macroglobulinemia with the support of the Leukemia Foundation as well. So our end game is obviously we want to get better breadth of knowledge of WM, but we also want to highlight treatment disparities between Australia and the world. And as we're getting more and more efficacy data from the more conventional randomized controlled trial type clinical trials, this disparity coupled with that efficacy information will hopefully facilitate access to subsidized novel therapies. So I'd like to finish by showing a screenshot of our first WhiMSICAL Study newsletter, which we're going to send around to community and doctors. Thank you very much.